very informative talk on accommodation in refraction. So I invite Dr. Dalia to give her talk on fine-tuning spectacle prescription.
So you have already heard what all things are to be done when a patient comes for refraction, the objective, subjective and the method of binocular balancing from the previous speakers. Now after the distant correction is over, if the patient is over 40 years, they will tell, I can see clearly at distance but can't read my newspapers or my mobile screens clearly. Here comes the importance of presbyopia correction. So the general guidelines for the presbyopia correction is the near card should be held at the ideal working distance which is customary to the patient, which might differ in different patients, and always choose the lens strength that makes the letters clearer and not larger. Always check the range of near vision and try to keep the near card in the midpoint of the range of a near vision. And in some cases, stronger ads may be required, especially when the patient might have to be given low vision aids. Now, a word about the relationship between age and accommodative amplitude. Accommodative amplitude is a difference in dioptric power of the eye when the eye is focusing at distance and at near. The difference is called the accommodative amplitude, which decreases by age. In a young child up to of 8 years, there is a good accommodative amplitude of around 14 diopters, and it decreases by 1 diopter every 4 years, so that from 8 to 40 years it decreases 8 diopters. So at 40 years the accommodative amplitude will be 6 diopters. It again decreases at the rate of 1.5 diopters, and at 48 years it comes to 3 diopters, and the rate of loss is less after that, 0.5 in every 4 years. So by 72 years of age there is no accommodative amplitude for a person. Now what are certain facts in presbyopia correction? For all optical calculations we keep 40 centimeters as a reading distance by default. So to focus from infinity to 40 centimeters, that is the accommodation amplitude, what is required is plus 2.5 diopters, that is 100 by 40 or 1 by 0.4 in meters, that is plus 2.5 diopters. And 1/3 to half of this accommodation has to be kept as a reserve for comfortable near work of the patient. And because the part of the accommodation is used for distance itself, hypermetropes will have early presbyopic symptoms and myopes will have a late presbyopic symptoms. And early symptoms and correction may be required in patients in professions with shorter working distance like goldsmith, watch repairers, etc. Now to find the near ad, the patient should wear the full distant optical correction, which have been found out already by what have been told, and the near vision is tested by the Jagger's chart. You can see the Jagger's chart. The chart should be held at the habitual working distance of the patient, and always inquire about the kind of near work requirement what is required for the patient. And the near visual acuity is recorded, which is the smallest line of letters, and in illiterate patients the smallest shape which is seen clearly. Now you determine the near ad to see the smallest letter what is required. Now the different methods to find, these are the different methods to find the near ad. We will go through some of the important ones. To find the near ad by determining the amplitude of accommodation, for this you determine the near point of accommodation with the help of the RAF ruler. While checking this, the patient has to wear his full optical correction, distant optical correction, and inverse of the near point of accommodation in meters is the near ad what is required for the patient. Now for an example, suppose a customary working distance of the patient is 40 centimeters and the near point of accommodation you find by RAF ruler is 50 centimeters. So the amplitude of accommodation what the patient has is 1 by 0.5, that is 2 diopters. This is what the patient has. Now, what should be the near ad for this patient for the working distance of 40 centimeters? So, the accommodation required for 40 centimeter working distance is plus 2.5. Of this 2 diopters what the patient has, half has to be kept as a reserve. So, 1 diopter has to be kept as a reserve and what is left is only 1 diopter. So, the amount of near addition required is 2.5 is required and the patient can use only 1 diopter comfortably. So, plus 1.5 has to be given as a near ad for this patient. Now, next is the tentative near ad based on age, which is routinely being used in practice, and we use the Hofstadter's formula to find the amplitude of accommodation at any age group. This is a Hofstadter's formula, and this is the chart showing the tentative near ad which is routinely practiced. Now, next is to find the near ad by the plus build-up method. So, for this also the best visual acuity at distance is accurately has to be corrected. This can be tested either binocularly or monocularly. After the distance correction is in the frame, plus lenses are added, increased in plus 0.25 diopter spherical steps to an amount so that the patient will first read the desired letters, that is N6 at the working distance. Now, to find the near ad by the near biochrome method, which uses the principle of chromatic aberration of the eye. It is widely used actually in spherical correction, which I have been told by Dr. Rani and Dr. Anita. The red is always clearer for myope, green clear for hypermetrope, and for a presbyope who is undercorrected, red and green will be focused behind the retina and red will be more behind. So, for uncorrected or undercorrected myope, if you ask, the green will be clearer, and for overcorrection, if it is the near part is overcorrected, the red will be clearer. So, the patient will wear the distant correction in the trial frame. The biochrome target is held at the working distance of the patient for near correction, and ask the patient whether the optotype on the red or green, which is sharper and clearer. If green is clearer, you add more plus, and if red is clearer, you slowly decrease the amount of plus what is present until the patient sees equally on both sides, which is a near ad required for the patient. Now, the objective method to find the refractive error at near point is dynamic retinoscopy, which have been described by Dr. Anita. The distant correction has to be borne in the trial frame. The near chart is held at the working distance and ask the patient to focus N6 letter. The room illumination should be slightly dim for doing the retinoscopy. Do the retinoscopy, the examiner sits at 40 centimeters and does the retinoscopy. The presbyope will show a width movement and you add plus spheres to the trial frame until the point of neutralization is reached. And near ad is the dioptric power of working distance minus the spherical ad what you have put in the trial frame for neutralization. Now, after finding the distant correction and near ad, you have to give spectacles prescription to the patient. The spectacles for under 40 years, it can be unifocal, which can be used for near and distance. And if it is over 40 years, a presbyopic patient, you will have to give either bifocals or multifocals as trifocals or progressive addition lenses. For a newer presbyope, it is better to always give progressive addition lenses, but always forewarn the patient about the peripheral distortions which will be present when they are first using it, and bifocals, when you are giving, there will be a clinically significant gap at the arm's length. It is always better not to change the ad type. If the patient is using bifocals, continue with that if the patient is comfortable, especially in elderly patients because of the risk of fall. Bifocals can be of 3 types. This is the flat top or the D bifocal, the half moon crescent or the round top, and the executive bifocals or the Franklin type. It is always necessary so that the optic center of the glasses should be in the pupillary axis of the patient for comfortable and visual clarity, and there comes the importance of measuring the pupillary diameter. You also have a far pupillary diameter and near PD. Near PD is always 3 to 4 millimeters less than the far. You can either measure it as binocular PD when you will have a single value, or you'll have a monocular PD when you will have two values which might be equal in both sides, or a slight difference might be there. It can be measured by using a pupillometer or a PD ruler like this. There are also websites can also have virtual PD measurement apps are also available, because all online trading is there. So you also have websites for virtual PD measurements. Optic center is also important in while you are prescribing prisms. Decentering of the lenses can induce prisms also. So after all this, when you are handing out prescription to the patient, what all things should be important? The name, the age, the date, the name, signature of the prescriber, the right eye, left eye, all should be properly seen for. The spherical lens and the cylindrical power, when you are writing, the plus or minus sign should be properly written. If the number is less than 1, always put 0 before the decimal number. If you are not having any power, write it as plano. The sphere, if it is not having, write it as plano. The cylinder, when you are writing the axis, better than using signs and all the arrows, everything, you write the number and properly superscribe the degree symbol, because otherwise it might be mistaken for 0. Then the type, progressive, constant wear, what all have to be written. Shell frames or multi-coated, whatever additions you can have, you have to write in it. IPD might be either by the optician, or you can even take it and write. Higher powers, always write the back vertex distance has to be mentioned. That is the distance between the lens in the trial frame and the apex of the cornea. If prisms are there, you have to note the power of in prism diopters, and the direction base up, down, everything has to be written, and the prisms has to be split between the two eyes. For near add, either you can write the near add what is required, or you can add with the distant correction and write the number what is as -5 add +3. So you can add that and write it as -2. And clinically necessary, other these material type, everything can be written as in a spectacle prescription for children. You can write polycarbonate lenses, colorful frames, everything like that. This is accommodative esotropia, child wearing executive bifocal spectacles. One-eyed patients, the other eye is emmetropic, you can give protective glasses, and if one eye is slightly myopic, you can write balance, so that the optician will put some minus lens on the other side also, because that will give a cosmetic appeal. Any other specific indications also you can write. This was before handing out the prescription, always have a word about choosing the spectacle frame to the patient also. This was a patient who came to me with telling that she went for change of spectacles. She had the new prescription, and what is present in her spectacle is the same. But she is not comfortable for her reading, especially when he is sitting. She is comfortable only when she is lying down. That was the complaint what the patient was telling. You can see it is a loose fit frame, and the height of the spectacle frame is more. So whenever this near part of the progressive lens will come to her pupillary axis only when she is lying down. So she is able only to, so the advice was given that choose a proper frame for that and have the same prescription. So always tell the patient when they are choosing the frame also. So to conclude, refraction and spectacle prescription is art of improving vision without medicine or surgery. It is always a problem solving. What we measure is always not what we give. What is comfortable to the patient has to be given. History plays a big role. And always examine, diagnose, and take treatment decisions. The goal is always a simple prescription which satisfies the visual need of the individual, and explain and show binocularly before you hand out the prescription to the patient. Thank you.